we're starting off with the Cambridge Rare Disease Network Patient Passport. And we've got CamRARE Managing Director Jo Balfour with us, and also Vaila Morrison, who is an architect by trade. She's also very closely linked in with CamRARE. I think she does some comms and design for them. She's also on our patient and public voice panel as well, so she's a very well connected person. They'll kick off with the patient passport. Then we'll welcome Helen Bufton, and she is a Lynch Syndrome UK trustee, also a Lynch syndrome patient, and she'll be talking about their patient passport that I think they developed with St Mark's down in London. And then we're very pleased to welcome Julian Barwell, who's a consultant cancer geneticist at University Hospitals Leicester, and he'll be talking about a Lynch syndrome patient app, which I believe is now available on the App Store and Android store as well. So that is available for download. Just very quickly, I thought I'd introduce who we are as East Genomics. So we are an NHS organisation funded by NHS England. We're one of 7 centres around the country, and broadly we comprise the Genomic Medicine Service Alliance, which is very much about embedding genomics, making it mainstream, educating the workforce, and also the East Genomic Laboratory Hub, which is really, as it says, the laboratories which provide and organise the testing on behalf of the region. I'm multitasking here, I'm letting people in as I'm talking, so apologies. So broadly there, you can see we're all about equity of access, so anyone who's eligible for a test that's on the National Genomic Test Directory and who could benefit from it should be able to access it, and that's one of our really driving motivations. We're supporting the establishment of testing pathways and services for cancer and rare disease. We're helping clinicians with requesting tests and education and training, and also introducing new models of care that support early access to genomic testing and high quality personalised treatments. And just to give you a sense of our geography, it's vast. It's the East Midlands and the East of England, so we cover 29 NHS trusts, and we have 3 laboratory sites. And I will just mention, we have a public and patient voice panel. Vaila is a member of our panel, as you'll see. And these are all people who have direct experience of genetic testing, either for themselves or someone for whom they care for. And we are actually recruiting to the panel. So if any of you have had experience of genetic testing, you can have a look on our website or get in touch with me directly. And we are looking to broaden our panel in terms of age to make it more representative, and in terms of background and ethnicity as well. So if that's something that interests you, as I say, drop me a note or have a look at our website. I will be circulating these slides afterwards, so you'll be able to find the links. So that's it from me, the boring bit. So I'll hand over to Jo and Vaila to talk about the CamRARE patient passport.
Thank you, and good multitasking there. So Vaila and I are going to whiz through a bit of background and an introduction to our rare patient passport, which we've been developing over the last few years. And I think if you can move on to the next slide first, I'll just tell you a little bit about CamRARE first, in case you're not familiar with the charity. But we are a charity based here in Cambridge, but we work very much locally and regionally with our rare community. We offer activities and a place to share information, knowledge and advice. We put patient voices at the heart of everything we do. So patient voices we provide a platform for, and we provide access to. We do research and we undertake projects like our passport project. We build networks and we organise lots of events and activities for those networks, such as our companies forum. So that's a forum for pharmaceutical and other life sciences industry companies. And we organise events. So you might have heard about our big event coming up later this year in November, which is RareFest. That's for everyone, for the public and our rare community. And in the alternate year, we do our Rare Summit, which is our stakeholder conference. So that's a little bit of a whistle-stop tour of who we are and what we do. And next slide. So launching into why on earth did we get involved in doing a passport? Because there's definitely some days I think Vaila and I think, why did we start doing this and how did we get involved? And I think the answer is because it's been talked about for way too long, but with little positive action. What we'll hear later from the Lynch Syndrome group is that rare disease groups were very much taking on the responsibility themselves to develop passports for specific rare diseases. And I think what we've always recognised is that there are tons of smaller, you know, perhaps ultra rare groups out there, and also individuals who aren't part of a group who were falling through the gaps. So we have a bit of a microcosm of that in Cambridge. So we have a group called Unique Feet, and Unique Feet is a Cambridgeshire and Eastern region collection of families with any rare disease and those who are undiagnosed. So what we do get on a daily basis is this really brilliant insight into how rare conditions vary, not just by symptom, but by experiences and by the barriers that they face. But I think Vaila will agree that most of the time we found a lot of common ground between the different conditions. So we were in a unique position really to look at the policy context of this and think, what can we do to take this forward? So in 2013, the very first UK rare disease strategy was launched, and it was highlighted way back then. So we're talking 11 years ago now. In that policy document, it said there should be something like a passport or an ID alert card for rare disease patients. Fast forward to 2018, and NHS England made a commitment in their implementation plan to actually introduce a rare disease alert card for all those who have a rare condition. It wasn't fully implemented, and many of our families told us they didn't know anything about it. Fast forward to 2020, Genetic Alliance UK undertook their own research and report, and you can find that online on their website. And it again was looking at the need for a rare alert card, and they were really clearly saying this is something that our community would value and that would be helpful to aid the communication between a family and a healthcare professional. So we were kind of stuck at that point in 2020, knowing for 7 years already that this is something that people wanted and needed, but not knowing a way forward. I think if you slip onto the next slide, Vaila's going to explain how CamRARE then decided to act and what was it that prompted us to do that.
Hi there. Yeah, so I think with the COVID lockdown restrictions, everything became a lot more focused, and people in our community group began to sort of raise concerns about what would happen if their family member had to go into hospital and they couldn't stay with them. If they have communication issues, what would that look like? What would happen if their regular team were dispatched elsewhere and they weren't able to see them? So I think the idea of a passport that had been identified, as Jo says, previously as a useful tool under normal circumstances seemed to be something that would be even more helpful in a time of crisis like COVID. Something that could help people communicate a rare condition that medics might not have seen before, the way that the condition affects you as an individual, and any complex comorbidities people might have. It would reduce the need for people to repeat information, which is something that lots of us have to do lots of the time, and provide a degree of independence for those who have communication difficulties, and also those who, when they're poorly, their communication is impacted, whether that's the communication that they normally would have. It's easier to sort of hand something over. So if you maybe jump to the next slide. This is my daughter Eilidh. She's 13 years old now, and she's non-verbal and has high care needs. So for her, it's not just the medical side that we need to communicate, it's also what help she need, what she can do, how you would communicate with her. and what care she would need if she was in a hospital setting, for example. Next slide, please. This is another little friend of ours from Unique Feet who sees up to 17 different specialists in 8 different hospitals. So something like a passport could help reduce a huge amount of repetition that his parents have to do whenever they go in to see a new specialist or different specialists, and also help to keep consistency between them. If you're seeing people in different trusts and different hospitals, consistency can be a problem. So if you've got something that everybody sees, then it makes things a lot easier. I think the next bit's Jo again.
Thanks, Vaila. And you know, just 2 kids in our group highlighted there, but I would argue that most people with rare conditions can see some sort of familiarity from that. You know, either communication is difficult because communication is intrinsically difficult for that person because they're non-verbal, for example, or just that awful feeling that you've got to repeat every time you meet somebody new. Particularly in a crisis situation, that's quite a stressful thing to have to do. So we decided that we would just give it a go. We thought, why not? You know, we're all locked down at the moment. This would be a great project to undertake during that time. It would give our families a bit of focus. You know, we could get them involved in supporting us and thinking through what might a passport look like, what did it need to contain, and then we could actually use them as the pilot study. So we began in 2020 during that COVID lockdown, and by 2021 we'd done our first consultation. So we'd worked with our Unique Feet families to find out what it was they wanted from a passport. We launched a report, so with the support of a company called Costello Medical, we developed a really comprehensive report. So we'd undertaken several things to get to that point. We'd given patients a survey to fill in before they tried a passport. So what's my current situation like? What are the big challenges for me when I go to a hospital or I walk through a GP surgery door? And then we gave them a passport to use for around 3 to 6 months. And then we did a follow-up survey. So how did you find the passport helped or didn't help? So we had a really nice collection of, you know, of information, but it wasn't a broad enough study. So fast forward to 2023, we repeated this. We made some tweaks to the passport template and we rolled it out on a much bigger scale. So we had over 300 people from across the UK, not just children, but adults as well with a rare condition. And we also surveyed healthcare professionals at this point to find out what would work for them. So in 2024, earlier this year on Rare Disease Day, we launched our second phase of the report. So if you want to get a hold of any of this information, if you want to have a look at the report, there's a lovely flipbook version on our website, or you can download it from our website. And we've kind of highlighted some of the key findings and data on that webpage as well. Next slide, please. I'm going to let Vaila do this bit because Vaila's claim to fame is that she kind of took her amazing architect skills and she's repurposed them as a graphic designer. So she's now our graphic designer for CamRARE, and she actually created the final passport template, which you can see here. Do you want to talk us through it?
So yeah, so we decided to kind of go for the sort of low tech option. That was purposeful. We decided, we speaking to our families, we felt that in the first instance, trying to create an app was too tricky. So we were trying to kind of gauge what information needed to be on the passport in the first instance and how we could make it short and snappy and get all the key facts across that we need to be able to communicate. So we initially started with a simple kind of paper version, but it soon became kind of clear that was actually what people wanted. Something that was actually a physical thing that they could hand over or point at in an appointment seemed to be something that people were keen to have. It also makes things like data storage a lot easier. People will hold their own data. We don't have to create a system to hold data. And one of the things we wanted to do with this, as Jo was saying, we've got such a variety of different types of rare condition. We wanted to try and make it as universal as possible. So this was the way that we kind of went. So what we ended up with was this template, which is a fillable PDF, and you can insert a photograph into it as well. And you fill it out yourself, or you fill it out for a family member, and that means that you can kind of change it, edit it whenever you want. When things update, you can update it kind of immediately. You can print it out as a double-sided A4 sheet and pop it in the front of your medical notes, or as you can see in the little photograph, we have trim lines and fold lines, which you can fold it up into a sort of alert card sized card that you can either keep in a lanyard or keep in your wallet. And if you fold it up into the folded format, you get the sort of the purplish shaded areas are the front and the back. So that's got your kind of key information on the front, and on the back it's kind of the top things that you need to know about me. So if you've got sort of 3 top key things about that the first person that comes into contact with you would need to know. So in the front it's mostly your medical information. On the back it's a lot more of your caring for me type information if you're an inpatient, or if we have a lot of people that use them for other things, for activities, as well as medical situations. So if you click to the next slide, we've created a user guide for people to help filling it in, sort of suggested text that you might put in the different fields, how to insert the photograph, how to get it printed if you don't have a printer at home, and that kind of thing. Click to the next slide. It's just a little kind of list of the sort of key features of it. Yeah, so that's it. That's the passport.
Thanks, Vaila. I mean, you can actually see it there on the left, where it's folded in a plastic wallet and on a lanyard. Next slide. So I just wanted to quickly show you a collection of some of the feedback from people, because this really captures I think the feelings of most. So that bottom right one, I tried to do my own medical summary, but it ended up being 6 pages long. This passport succinctly summarises all my key medical information, and it was and is being accepted by various healthcare professionals. So that feeling of, lots of people have said to me, how on earth will I fit everything I need to say into 2 pages? And the trick is to be succinct. So what we've done is we have a hover function. So as you're filling in the form, you can click on the hover, and it suggests the types of things that you might want to write in that section. And it just helps cut down to the key, essential, important information that people can see at a glance. There's a comment there from non-native English speakers and how great it is to be able to communicate information in a format that's easy for them to use. It's easily digestible when it's written down. I don't know about anybody else, but I know when I'm in appointments and I've got to listen to a lot of information, a lot of it goes in one ear, out the other. And there has been some research by a group called Cognitant exactly about that point. How much do we actually retain from an appointment? It's quite shocking how much we forget. So it's about, you know, being able to present the full picture as succinctly as possible, but being able to leave it with someone as well, be able to give it to someone to actually pop in a folder so they can look and digest. Validation was a big thing as well. I think a lot of people felt really strongly that suddenly having something that was built by the community for the community, that, you know, had the rubber stamp of a well-known umbrella organisation, actually gave it some validation. So people felt more believed. And I think that's really key in giving people those advocacy skills that they need to be able to share their story. So where are we now? Vaila, do you want to just do a really quick run through of where we've got to with the recent launch?
Yeah, so we've had, as you can see there, 815 applications from individual people. Some of those are, we've teamed up, we've had quite a lot of patient groups apply, as you can see, 44 there, and some healthcare settings as well. So we've been partnering with those patient groups to create a version of the passport that has that patient group's logo on it. So it sort of feels a bit more, belongs to that group. So that 815 number is a lot of individual people having the sort of generic CamRARE passport, and a certain number as well all have applied as part of their patient group for a sort of branded patient group logo. We're working with people across the world. It's gone international. So we've got people from 28 different countries represented now in our applications, and we're working with a couple of different healthcare settings over in Australia, who are trialling the passport with their groups. So it's all very exciting.
Thank you. Next slide. Thanks. So I think the key here is that there's no barriers with this passport. We want to make this passport freely available for anybody, anywhere in the world, whatever age they are, whatever disease they have, as long as it's rare and undiagnosed, to be able to have something that's recognised, it's consistent across the world, and it really is a starting point for a much, much healthier conversation between the patient, the family, and the healthcare professionals and other professionals that they work with. So I think the last thing to say really is, if you want to get involved, if you are an individual with a rare disease, or if you're a parent or caregiver of somebody who has a rare condition, if you are a patient group and you would like to partner with us on a passport, we can put your logo on our passport and you can circulate it to your community. We provide the resources to help you do that. If you're a healthcare setting, we'd love to have a call with you, and we'd love to talk to you about how other groups, like we've mentioned in Australia and the Welsh Swan Clinic, are partnering with us to trial the passport in their setting. So they're undertaking the surveys as well, and they're having nurse navigators help people fill the passports in. So there's lots of different ways you can get involved. There's lots of different opportunities, whatever way you're involved in rare diseases, just head to our website or scan that QR code and we'll get in touch. I think that's
Fantastic. Thank you both very much.
Thank you.
Yeah, I can see if you're having multiple appointments a week, was it Ruben, and across multiple specialties, that Groundhog Day of having to repeat the same information, it's hugely important. If anyone does have any questions, I think we can maybe take a couple now. I suppose a big one might have been, where do I sign up, which you've covered off on screen. Does anyone have any questions or queries for Vaila or Jo? If not, we'll move on.
I think if not, there's one question that comes up really often that it might be worth answering, and that is, why did we not go for an app? We're constantly asked that question, and the answer is because that's not what the community asked for in the surveys. Over 75%, I think it was, of people said, for now, a fillable PDF is the best format. And the logic behind that is that every hospital and trust and healthcare professional, whether they're allied healthcare professionals or based in hospitals, they use different systems. And at the moment, those systems don't talk to each other. So there's concerns about how accessible it would be, and also concerns about cost. At the moment, we can give this away for free to anybody who needs it, which is really important. And we're open, I think, for the future to exploring those ideas. But for now, it's great that we don't need to store people's data. So that's really where the decision lay.
Great. The most
we have something similar in Scotland, but it's a paper format. Can we go onto this one ourselves anyway?
Yeah, this
Yeah.
this is the paper format. You know, you print it out.
It's more a booklet that we have in Scotland. It's more a sort of booklet, whereas this would be much easier to carry around. So I just want to check that we're okay to use that.
Absolutely. So all you need to do is if you scan that QR code or you pop to our website, there's a link on there, and it's a really, really simple form. You just fill in the form to say who you are, whether you want to sign up as a healthcare setting, a patient group, or an individual. And once you've done that, we then get in touch to say, here's the stuff.
Right,
here's
perfect.
This is how you fill it in, etc. But if you want to do it as a setting, then we would probably just have a quick call with you to work out, do you want your logo added, and how do you want that to work?
Yeah, no, I'm just an individual, so yeah, I have now completed it.
Awesome.
Thank you so much.
Thank you for the question. Thank you, Jo and Vaila. That was really informative, and it's already sparked a sign up, which is good. So we'll move on now to Helen Bufton from Lynch Syndrome UK, and she'll be talking us through their patient passport. So if I could hand over to you, Helen.
Hello there. Good afternoon, everybody, and thank you for inviting me in. Now, you'll have to bear with me because I don't normally do this kind of thing. So I'm just going to give you a little background about Lynch syndrome. So we are a small charity, and we were created by a group of Lynch syndrome patients, most of us having undergone cancer treatment ourselves. Many years ago, we set up a Facebook page, and we soon realised that we needed to educate medics and the public about Lynch syndrome and the implications of having a mutated gene. So our Lynch syndrome passport is a hard copy, and it was designed by Tracy Smith, one of our trustees, in conjunction with Dr. Kevin Monaghan of St Mark's Hospital down in London. So as Lynch syndrome patients, we realised that there was a huge lack of support and information material for patients, with most of us having to explain what Lynch syndrome is at every medical appointment, the implications of having a positive diagnosis, and any treatment, surgery, screening and procedures that we have to go for. So the passport is designed to fill that gap with a little bit of information about Lynch syndrome, our recommended screening guidelines, and pages for us to record which mutated gene we have, any procedures we may have had, and when our next screenings are due. So what we did was we asked our Facebook page members and we designed the passport for patients. We asked them what would be useful for them to take to their appointments. The information in the passport is understandable, as clinicians often use medical terms that we don't understand. And it's also a place for patients who have had a lot of surgery. They can keep track of all their appointments in one place. So we have got an extremely supportive closed Facebook support page, which means only members can see posts or comments. And this is where we post any new information that we receive around Lynch syndrome, treatments, etc. We do also have a website page, which is currently under reconstruction. I'm sure Ian can move the slides to show our website page. Thank you, Ian. So if anybody would like a copy of the passport and also a copy of the Royal Marsden Beginner's Guide to Lynch Syndrome, you can email us at syndrome.uk.org and post copies out to you. So we also hold an annual conference with Lynch syndrome experts, giving us talks on new developments in treatment. And next year's conference will be held at the University of Warwick on March the 22nd, which is also International Lynch Syndrome Day. And that's our passport. Okay, thanks.
Thanks, Helen. Thanks for the question, Jo. That leads us very nicely, nice segue into Julian Barwell's section. So Julian's going to be talking us through the Lynch Syndrome app, which he developed with colleagues at University Hospitals Leicester. So Julian, over to you.
Thank you so much. So during the COVID pandemic, as part of one of many midlife crises, I returned from the wards after 19 years of being in clinical genetics, and I was telling her about this, and she said, "Have you come out of retirement?" And I sort of shrank like the Wicked Witch with Dorothy throws water on her. But what I realised on the ward is that there is definitely a mismatch between what is going on in the clinical reality of the NHS and in our pharmacies, particularly on wards in busy outpatients and general practice, to what we think about from a molecular perspective in clinical genetics, supporting people with rare diseases and their clinical decisions. And I wanted to try and bring that together. And I was mentioning that at a public policy projects meeting, and ran into a couple of groups who had very similar thoughts. And I think this feeds in quite nicely after these first two talks to try and think, can we develop dynamic personalized care records that are looking at rare diseases, but also potentially pharmacogenetics and to support prescribing as well. So this is in support with Instant Access Medical, who developed GP personalized care records, particularly for the Special Olympics, but also with Signogene, who have pharmacogenetic pull-through data that I'll be talking about. Thank you. Next slide, please. So there's obviously been a lot of work with Lynch syndrome, and we work very closely with Lynch Syndrome UK. Not only have Lynch syndrome almost been able to develop their own NHS by having their own specific genetic counsellor, MDTs. We now have a database for sorting out bowel screening on a regular basis, a psychologist, but also they're very useful guides for clinicians as to how to manage these, which have been approved by the Cancer Genetics group, which give risk figures which some people find helpful, but also advice on things like aspirin and having a breath test to look for bacteria in the stomach, and also guides as to gynecological review, for instance. So we're in a pretty good space for Lynch syndrome, and we're also involved in research looking at how patients find information when they discover they're at risk of conditions. So we've got a pre-survivorship sociology project as well, and we teach all of the medical students about Lynch syndrome. So all that go through medical school get some learning about, in particular, the MSH2 gene, but the principle of Lynch syndrome, and of course other rare disease and cancer susceptibility syndromes. Next slide, please. So one of the first things we did with Instant Access Medical, and I was saying how important personalized care records were for people with rare diseases, and Dr. Stan Shepherd reached out to me and said, yes, we know this is an issue from the Special Olympics and how much unmet medical need they are, particularly for people with learning difficulties, but certainly across the board for rare conditions. So the first thing that we did alongside Ipsos Mori, who are more famous really for political polling, really, but are interested in the healthcare space, and they supported us alongside Lynch Syndrome UK to ask 106 patients as to what was important for them. Now, of course, we appreciate that this is a biased group because they were online and answered online. So it's no great surprise, perhaps, that those that answered did express some interest in some healthcare solutions. And a number of our patients took part in supporting us in thinking about how could we provide dynamic solutions for patients at risk of bowel and gynecological tumours. And this is, of course, important for other patients with conditions which impact beyond one single healthcare provider. So if you're at risk of coronary artery disease, you're going to need the support of your cardiology department. But for instance, von Hippel-Lindau syndrome affects the eyes, the brain, the spine, the kidney tract system, and also an increased risk of hormonal tumours. So a lot of different healthcare professionals, and it can get very complicated, as has been already described. Next slide, please. So we have come up with an app. Now this is, I think crucially, it's an early phase. This is patient entered by and large. So there's screens which will take people through a letter for their doctor or a letter for their relatives. It has screening reminders. It has red flag symptom checkers. And also it has a clinical dashboard, and because it's patient entered, it does make it a little bit easier with regards to things like GDPR. And the idea is, because a lot of doctors are often quite visual learners, it does help give a single viewpoint of how that patient is getting on with their care. So we have a red, amber, green traffic light system across 6 domains. You score 3 points if it's green, 2 if it's amber, 1 if it's red. So the score is between 18 and 6. And so this gives the potential for a service evaluation type audit. And if you track by region, you can get a feel for where your patients are in your centre. So this is across things like aspirin and bowel screening and gynecological review and talking with relatives and Helicobacter. So you get a score, and it's based really on, is it done and up to date? Has it been discussed, or has nothing been done? And that's the 3, 2, 1 score. So you get a visual representation. And the idea that I have is that when you're talking to a clinician, you've basically got 10, maybe 15 seconds for them to get it. So when you're having that conversation, and the idea is that if you've got a personalized care record, then in a few seconds, you can hopefully personalize that discussion to what's important for you. And you won't have to go through everything if it's already in hand. Next slide, please. Now, I wanted to mention precision medicine and genomics. So classically, clinical genetics is the study of the past. So your oldest gene is 2 billion years old. I'm a bit cross that my body is all it could come up with, to be honest, after 2 billion years, but there you go. So genetics is a study of how you've got to here today, whereas genomics is more crystal ball gazing in terms of trying to be better at predicting the future. So genetics is about reason and genomics is about risk. And the intersection here is precision medicine, which is the third R, which is response. Can we work out what will happen if we give somebody a particular drug now, be it for a cancer, for instance, or if they've got a particular medication, we give them the right dose, or it may be, as we've all been talking about recently, microbiology, be it bacteria or viruses. So that's the intersection. And we wanted to be able to use this type of technology to help people with their prescribing decisions as well, because what we find is that although there is increasing amounts of genetic testing to try and predict response, and we know many drugs don't work because of the way that the body metabolizes it, or can cause side effects. And there are many drugs which have huge number of problems in this domain. Classic examples being warfarin and clopidogrel for blood thinning, but also things like statins. And many people know that statins can cause things like muscle aches or problems with the liver. And we're in a situation where we're causing huge amounts of harm. And I always make the analogy with the airline industry, where they went from the first flight to going to the moon in about 60 years. And it's safer now to fly than it is to actually drive to the airport. And I always try and remember that mantra when I'm going on an aeroplane. So I need to fly to the airport, perhaps. But the reality is that we tolerate a huge amount of error in healthcare, and we need to really start to get on top of that in the 21st century. And this is a step, hopefully, towards trying to do that with more accuracy, with regards to supporting people with rare disease, but also supporting people with their prescribing. Next slide, please. And this is really giving a sense of the scale. So 6% of medical admissions are due to drug errors. And we're talking about 300 poisonings per minute in the NHS alone. So we make over 300 errors per minute with our prescribing. Now, we are getting to a point where drugs will not be able to be prescribed until people have had genetic testing. And we know that there are starting to be big legal cases, like in Hawaii, for instance, with clopidogrel, which is used to prevent clots after stents, like aspirin or warfarin, for instance. And the drug just doesn't work in half the people from Hawaii due to the way the drug is metabolized. And you don't know it's not worked until you've had a blood clot. And by then it's too late. And this is where a static PDF in your drawer is not helpful, because what you really need is that advice to come through at the point of prescribing. And as was mentioned earlier, the problem is that the NHS and throughout the world, they all use different systems. And actually, although digital poverty is an issue, throughout the world, actually, more people have got access to mobile phones now than they do to healthcare. So these sorts of solutions could be helpful, but they obviously need a lot of support. And our hope when it comes to prescribing is that people will be able to then give their feedback as well. But unlike Amazon or eBay, the feedback will be specific to your genetics. So the next person who comes along can see the side effect rating or the effect rating of a drug actually based on their own genetic profile. So you end up with a personalized Amazon rating for your drug, personalized to you. Now, I was down in London on the tube the other day, and I saw personalized dog food adverts, and I've seen them on the television as well. So we're personalizing what we're doing to dogs, and yet we do 300 poisonings per minute in the NHS. So I do think it is time that we started to really personalize, and we're going to look back in 20 years and think that this was Elizabethan, and I don't mean Elizabeth II, in our approaches to prescribing everyone leeches. And I'm sure it will be the same in the future when we think about prescribing. We need to avoid so many errors. Next slide. So how does it look? So here you've got the personalized care rating for Lynch syndrome. We've got the red, amber, green. So you can see this individual's had bowel screening, but it's not in date. Taking aspirin, had Helicobacter, but they've considered talking to their relatives and they've been given the information, but they've not done so yet. So that individual has scored 16 out of 18. Now, for me, I don't know about you, but for me, I can hone in on where that patient is at in 5 seconds. And personalized care, of course, can mean different things to different people. Personalized care also means if you die, what happens to your cat, for instance. So these can be personalized in lots of different ways. And our idea is that you could be able to download this type of record if you're in A&E and you're waiting. And therefore, by the time you see your clinician, you've got a personalized care record for your particular condition through an algorithm. You may have previously sent saliva sample off, and therefore, if you need a painkiller, we know some painkillers don't work, and the doctor just goes, well, it's one of those things. It's not one of those things. It's just it's not personalized to the individual. Some painkillers don't work, some are fine, some of them knock the patient out and they end up in respiratory arrest. And these are the 300 errors per minute. Now, we know in Lynch syndrome, for instance, sadly, some people develop bowel cancer and they may need chemotherapy. Now, already you need to have genetic testing prior to that chemotherapy. So we're developing a pull through. If you press keep going, and this is for what's called DPYD, which is a genetic test for whether or not it's suitable for you to take fluorouracil, for instance. And what we have developed is the ability to pull through the genetic data so that the individual can type in their drug and it will tell you whether or not red, it's not safe, amber, it's safe but needs changing, or green, it's fine. And if you can do this for this drug, you could do it for warfarin, statin, and away you go. And then we have 21st century healthcare. So we've got another rare disease group very interested in this and have agreed, if this goes well, through our release through Google and Apple, that they will take it up. But we see this being something we could develop an oncology app. There's interest in palliative care for prescribing decisions, as well. As I said, I can see it being applied in a lot of centres, and certainly for people with rare diseases, it could be very useful to have the clinical dashboard. But I could see how this could be applied. And if you're on your health journey on an aeroplane, too long of patients being the passengers, this is the beginning of making them the steward. And in time, we want them to feel empowered enough and enabled enough and inspired enough to be the pilot. But this is all the things that I've mentioned today are about going on that particular journey. So yeah, so we've developed this alongside patients and alongside a very strong outreach model. Our projects are all co-creation and trust-based projects with patient groups and community groups. We do a lot of teaching, undergrads, postgrads, but we also teach in communities and children as well. Done a huge amount of work with my partner in crime, Jo Lowry, who's our genetics and genomics, mainly genomics manager started with the 100,000 Genome Project. And she's been instrumental to huge amounts of this work. We've just got a program grant with the NIHR to develop a decision aid tool for individuals with thoracic aortic dissection. This is where the aorta can tear. And of course, if it does tear and if you survive, it can start affecting a number of different organs. And it can be an inherited trait. So a lot of these individuals, again, need that holistic overview and support. It's often difficult to diagnose in A&E. It's often misdiagnosed for a heart attack. And of course, if you give people a blood thinner, it could even make things worse. So we feel that this can certainly help patients, their relatives, but also their clinicians, not to replace analog care, but to enhance it and to personalize those discussions along the way. And obviously people with thoracic aortic disease often have other medical issues as well, and maybe on medication. And this is all being linked in with the electronic healthcare records legislation as well. But we think patient facing solutions for this are the way to go, because of course they can work anywhere in the NHS, but also internationally. Thank you so much for the opportunity. Very happy to take any questions, and I hope people feel that this builds on. We're nowhere near as far as being into multiple countries and multiple different conditions, but we see this very much as the beginning of this sort of personalized medicine journey. Thank you.
Thanks, Julian, again for really interesting. I love the idea of getting a plane to the airport. I'll try that to reduce my risk. So we've done the questions, I think, really. I just wanted to pop this slide in. It's just, and we will circulate the slides. It's just some QR codes and to some sources of patient information and resources and support. We do have a regular newsletter that we put out. It's quite clinically focused, but we do have events and opportunities in there that may be of interest to patients. So if you want to sign up, please do. And just to say, we are on X and LinkedIn, and we have a YouTube channel as well. So I think we'll conclude there and say thank you very much for joining us.